Good morning. I'm actually filling in for one of my colleagues who had to drop in the last moment. Of course, it is an area of my passion for me. This is totally different from what I presented in the morning. Acute MI, plaque rupture, nature has created. You go in easily, you can cross the lesion, put a stent, save the patient. Time is crucial. Here is opposite. Here the patients come with blocks which are long-standing, sometimes months, years together, decades-old blocks also. But there will be scenarios where medical management might not be enough, and we might have to intervene and save these patients. If you see angios like this, 100% blocked LAD here, not seen at all, and branches coming there. Very, very old block starting point, not much area to enter. These blocks might have got so calcified, so hard, it's very difficult for us to cross these lesions. You can see this block, dense calcium everywhere. We don't know how to go about long time, for years together, in abnormal anatomies, in areas where it's occluded and branches are coming. You try to go here, and it will not go. And these people might have been tried for an angioplasty at many centers, failed, multiple attempts. And cases like this, abrupt closure, and then you got branches which will not allow you to enter. The wires we use cannot go through. We have several hardwares available. These are special techniques are involved, technologies are involved, and skill levels are different, complication levels are more. These are called the chronic total occlusions. There will be patients who will benefit from these procedures, but these are called the final frontiers in interventional cardiology because a lot of success rates are not that good. With experienced hands, you might touch about 95% of the times hardwares, and sometimes you should be aware complications might happen. Or not all patients with a total occlusion of the artery need revascularization. If it is a single vessel or in an area which is not much, or they are not symptomatic, we can carry out medical management as well. How we proceed with these techniques, because the audience is different, I will not go into the technical details, but just to show and showcase some of the strategies we use. We have to know the interventional cardiologists who deal with the CTOs. We know what the lesions are made of. We have certain tricks to go through certain microchannels which might be there, and we have tricks to go through the soft tissues, loose tissue tracking, and there are specialized techniques as well. So I will just show that in these cases you might need more time, more radiation, more contrast, complications. Our labs are equipped with all the necessary repertoire of equipments and the strategies to take care of the complications should they arise. The usual CTO, the Chronic Total Occlusion Toolkit, these are, as I said, skill is also needed apart from the toolkit, because apart from the usual ones, my CTO toolkit, these are all technical terms which you need not be aware. If you have this basic toolkit and you should know how to use them, you will be able to do a good job. See this case, 100%, there is no way you can enter that type of disease. This patient, usually when you find multivessel disease, the CTO, surgery is the best option because success is guaranteed. The surgeon can do a good job for the grafts. But this patient with a muscular dystrophy, no way surgery can be done, respiratory muscle weakness, so we have to go use our techniques. I will not go through the details, but just to show that these are the patients where you might have to use different techniques. You are injecting from the right coronary, and when you see the left coronary, you have some idea and see in multiple planes where it is, use our imagination and use our finesse to go through that with different equipment. See, you're trying to see the wire there. We shape the wires. We take different wires with different types of strength characteristics. Some which can, like a spear, you can penetrate. For some, you can do thread it like a knife, skill knife. So these are all special techniques. We're using a different strategy to cross the lesion. At every point, if you find that the thing is not going, we are checking it by the contralateral injection, and you can go sometimes up to one point and it doesn't go. Then you have to change the wire. We have some catheters through which we do. You can see the microcatheters. Then we can change the wires and see what is happening, and you can see how things can come out. These are all high technical expertise needing techniques and technologies. You can see the dark black wire, which we normally don't use in angioplasties. They are made of special coatings. And then once you go through, we use different, again, change the equipment usage is very much. Radiation, we should be very careful. Dye usage, we always keep it minimum. And then just to show that we have made progress up to there. And finally, of course, with all our techniques, we can go in and then do the ballooning and then see the final result. So this is the gentleman with limb girdle muscle dystrophy, and finally we could give him a good LAD. Once the LAD is done, doing the rest of the vessels. This is the second vessel, which was critical blocks. These are simple game. It just takes 10 minutes. You call him on 2 weeks later and tackle that. These are all simple games. You can get a good result from here. This is a good double vessel angioplasty for the complex cases, which once upon a time we had to push to the surgeon, despite knowing the consequences and risks of a limb girdle dystrophy or diaphragmatic palsy or intercostal muscle weakness. So, the message I want to convey is, if you find patients who are high risk for surgery, even with multivessel with CTOs, we still have the capacity to deliver a good job. Tough calcific, entire vessels will be calcified in some people. My colleagues have shown some cases like that. Entire arteries will be calcified. It doesn't matter. The technologies now are available with us where we can show this chronic total occlusion, the special wires. We will not go into the technical details, but again, we can deliver a good job. We should have a repertoire equipment. This is where angioplasties are not the same. The word is same, but what we do is totally different. And you can see things don't go, and then we have to use special techniques. There are something called like guide extensions. We go inside and do the job, and I'll show you the final result. And to answer that question about dissections, whenever we do angioplasty, dissections are always produced. This is a controlled dissection, and we put a stent and then cover it up. That is how the technology of angioplasty is. And once you deliver a good job also, the first thing, finally, the access. Many a time we do the procedures from the hand, but in some cases where the pulses are not good or in chronic total occlusions, double angioplasty where access is there, we cover it up with a closure device. This is one of the, you can see this type of, there are some anomalies, arteries which are in chronic total occlusions, and they're in abnormal shapes. Like this is called the epsilon RCA. Again, I will not show in detail. Even to cross with a balloon is very tough. These wire, the crossing with the wire is tough. If you cross with the wire, the balloon won't go. If the balloon goes, the balloons will rupture. So these are all the challenges in these cases. The biggest challenge is wire crossing. With the current wires, of course, we can. You can see how difficult it is. I don't know whether you can appreciate. Whatever balloon we are inflating there, the dye there, the balloons get ruptured. The calcium is so strong and spicules are there. So we have special techniques there. We do rotablations and then get the job done. So chronic total occlusion, when you are going in, you should know, and you should know that all the techniques and technologies are in your hand, and the comfort level should be good for doing this type of intervention. These interventions are called as level 4 operator CTO techniques, and only few centers are advanced and then equipped for doing these procedures. This is another rare scenarios where I have shown you before. There are special catheters through which you can pass two wires, one from the tip and one from above. So when you don't have a place to sit and do the angioplasty, we use these dual lumen catheters and then do the job. You can see that one foothold and then you do the job. This is the case. 3 times failed angioplasties elsewhere. You cannot do the job unless you use these special technologies and techniques. You should see this angiogram to know how, I call it the slippery slope. Slippery slope because whatever you try to do, nothing will enter. So you have to use the double lumen catheters and then get the answer. So all the technical terms and the special wires and all these things are not for a routine discussion. I'll just show you the final result, how it looks. It looks phenomenally, very, very gratifying. The CTO, sometimes the patients are so symptomatic, our LV dysfunction drops, and if you can get a good job with least complications, the results are dramatic. Again, a blunt cap, multiple double wire, dual lumen catheters, special techniques. Again, final results are always gratifying. Retrograde techniques also sometimes we do. These are even more complicated level 4 techniques, just to show that we have the ability to cross over from one side through the collateral, enter the arteries, get into the distally, from you enter the artery from below, and then do these techniques. If we see that, it looks all like magic. That's what? The mastery, the marvels, and the myths. That we have shown you, I think all the sessions have been showcasing the mastery levels, the marvels the technology has given us, and then of course the mastery to utilize these marvels into patient outcomes. That is what it's all about. So a tremendous amount of work we have done. And of course there will be lots of myths in this area. I think that is where interaction will clear those myths. Thank you.